connected to the systemic circulation through the umbilical cord, which contains the umbilical vein, okay, and which takes care of blood circulation going to the heart and all systemic circulation as well. And in fact, if you will see it over here, the blood from the placenta goes into the inferior vena cava, then the right atrium, which further left atrium, then left ventricle to the aorta, and from the aorta, as we all are aware, like the typical adult circulation goes to the head and neck, finally going to the returns via the superior vena cava, and finally into the right atrium. And through the right atrium, if you look carefully over here, not just it goes into the left atrium via the foramen, but also from the right atrium also it goes to the right ventricle. And from the right ventricle, it further goes, of course, to the pulmonary artery. And from the pulmonary artery, it goes to the aorta via the patent ductus arteriosus. And of course, then to the lower extremities and finally blood to the placenta. So two things which is really special to the fetal circulation is foramen ovale and the patent ductus arteriosus. Okay. So these are very interesting things, and cardiac anomalies which can occur due to the result in the defect in the structure of lung, heart, and the vessels, which is present at birth. And these lesions either obstruct the blood flow in the heart or vessels near it, or even alter the pathway of blood which is circulating through the heart. So, in a broad basis, we try to classify, even on the babies which are born is like pink baby or blue baby, right? So, the pink baby is the acyanotic, and the blue baby is the cyanotic one, cyanotic heart disease. So, in the pink baby, what is going to happen is there will be a volume or pressure overload. So, can someone give me some examples of the acyanotic congenital heart diseases? Any example? You can use the chat box. Otherwise, to try to make the concept more clear, what happens in the blue baby, in the the cyanotic one. So the cyanotic one, what will happen is there's either less or increased pulmonary blood flow. But of course, the baby will be cyanosed. So what will exist for the baby, as I was telling, the wall pressure. Okay, so maybe it's really pink, but the problems can be is PDA, patent ductus arteriosus, the DSD, or ASD, even coagulation of aorta as well. Okay, how the babies are the ones. What will happen is the dirty blood, the deoxygenated blood, is going into the systemic circulation. So that is going to happen through tetralogy of Fallot, transposition of great arteries, and the tricuspid atresia. Yeah. So coming to the atrial septal defect. So what happens is we all are aware that not only this is the most common uh, congenital heart disease, but also, in fact, as we all are aware, like up to 50 to 70% of the congenital heart disease are the ones which will be typically even ostium secundum. In fact, ostium secundum is there, primum is there, and sinus venosum. So even in the ASDs, the secundum is the most common one. Then comes the primum, then comes the venosum. So ASD is more like an abnormal opening in the atrial septum, which allows oxygenated blood from the left atrium to mix with the deoxygenated blood in the right atrium at a minor pressure difference. And the right atrium receives blood from the superior vena cava, from the inferior vena cava, as well as from the left atrium. That is the one which leads to volume overload and also pulmonary congestion. And as I said, it like on an overall basis among all the congenital heart disease, the occurrence rate is like 4 to 10%. And yes, it is more common in females. Okay. For the ostium secundum, as I had already said, see, even on a normal basis, the ASD patients are mostly asymptomatic. But with the passage of time over years to decades, patients may experience those symptoms depending on the type and the severity of ASD. In fact, those kids will be getting tired during the feeding, and what will happen is even the babies eating, so they will be having shortness of breath, fatigue, sweating, palpitations, or even their milestones of growth will be retarded. Okay, so ostium secundum is presented part of the cell. Primum is the which below the diagram is useful. You can see. So them as venosa. Okay, so why it's called this? Because it's at the site of the pia vena cava. This. What is this diagram which you can see? Everyone uses that, right? So is this? This can be a typical cue for you guys. They will show and they will ask, what is the diagnosis? So this is a phonocardiogram, okay, on notation. So what you notice over here is S1 is normal or abnormal. So S1 is normal. And in S2, you
लो
notice something special.
या वो
So it is widely
लोकेशन भेज दिया मैंने
split
बंद
and
ठीक ठीक है ओके थैंक यू
okay. Aditya, please mute your microphone. Thanks. I know your order has been sent. We all can hear now. So S2 is widely split and fixed with accentuation of the P2. And what is the type of murmur which you can hear? It is called as a injection systolic murmur, right? So S1 is normal, S2 is wide and fixed split with P2 accentuated. What is the expected findings on a chest x-ray of a patient like this? So what do you think? What do you notice over here? We had a session also on the chest x-rays, right? So what do you notice over here? I have also put up the markings to make it easier. So for example, on the basis of cardiomegaly, what do you think? So we can notice there's mild to moderate cardiomegaly. And there, how about the right atrium? If you'll notice, is it normal or abnormal? Of course, the RA and RV are both enlarged. And then the pulmonary artery segment, they're prominent, isn't it? And even the pulmonary vascular markings are also prominent. So this should make our suspicion about ASD. So can someone recall what did we learn in our just last one or two sessions about the ECG changes? What do we notice? So the first thing was right axis deviation. Yeah. Right bundle branch block. We also notice over here. And there is RV strain pattern. Isn't it? RV strain pattern because the QRS is positive, but the T wave is negative over here. And what else do we see? So looking at this ECG, if you get this, how will you say ostium primum secundum? So it is right bundle branch block with left axis deviation, which means it is osteoprimum. Yeah. And if it will be right axis deviation, then it would be ostium secundum, isn't it? What was There were so many signs also we had spoken about when we did our on ECG session earlier. Anyways, so regarding the management, so what happens is most of the babies by the end of the first year itself, it will close. However, if the baby's heart hole size is of like 3 to 8 millimeters, they may need supportive medical management using digoxin, diuretics, and also the prophylactic antibiotics, in fact. Okay. And yeah, a lot of times it may get closed as well with the passage of time. However, some of those patients may need, if the defect is more than 8 millimeter, surgical repair will be needed. And if spontaneous closure does not occur by school going age, the surgical repair becomes essential to prevent lung problems that will develop from the long time exposure to the extra blood flow. And the surgical repair should be done, yeah, with a stitches or a special patch. The material which is utilized for the patch closure of ASD may be the patient's own pericardium, in fact, and or even sometimes maybe the bovine pericardium, or what is called as MSET. There are some of those Gore-Tex, Dacron, commercially available stuff as well, which can be used. So what do we see in this one? This is a VSD, isn't it? So this is an abnormal opening in the ventricular septum, which allows oxygenated blood from the left ventricle to mix with the deoxygenated blood in the right ventricle. And the right ventricle receives blood from the right atrium as well as from the left ventricle, leading to volume overload and pulmonary congestion. In fact, the VSDs are the most commonly occurring types of congenital heart disease. Okay, so even more than ASDs. Okay, but in ASDs, if you all will remember, ostium secundum is the most common type of ASD. Yeah, so the percentage wise, VSD is like 14 to 17%. Not too much more than ASDs, but certainly slightly more, definitely. So, what are the different types of VSDs?
Perimembranous muscular inlet outlet.
Wonderful, wonderful. Very, very happy to hear that. So, as you can see, try to remember these diagrams. It will, if you'll remember these diagrams, no, you will never remember need to recall anything theoretical and all. Try to think of those ventricle, what could be the possible positions. So one is a supracrystal. Supracrystal, what will happen is it is just below the aortic valve, okay, at the LV outflow tract. Then is the membranous VSD. Membranous VSD is the one which is just inferior to the crista supraventricularis. Yeah. And the last one is muscular VSD. So, of course, so it will be in the mid to apical interventricular septum. And being clinicians, we are interested. How about the signs and symptoms? Sorry. So the signs and symptoms, they tend to change with the size of the defect, and the clinical symptoms are usually not seen at the birth. However, because of the continued high pulmonary vascular resistance in the newborn, the infants with moderate to large defects will become symptomatic within the first few weeks itself. So there will be shortness of breath, poor growth, failure to gain weight, pounding heart, even frequent respiratory tract infections as well. And yes, if there will be shunting, so for example, the impure blood goes to the other side, patient will develop cyanosis, clubbing, and also the distress as well. So, okay, so this is the history which we will come across. So how do you diagnose? So the patient comes to you, okay? And as I said it, I'll try to give you memory clues always of the VSD. So you have a phonocardiogram. So what type of murmur will you hear? So on auscultation, you hear is a pansystolic murmur, okay? Where the S1 is masked by the murmur and the S3 can be heard at the apex, right? And what do you see in the chest X-ray? So what do you notice in this? I have already given you all the hint as well.
Cardiology is present, but on the mark I can't see exactly clearly.
Hmm. And what else?
Waterline, can see cardiomegaly. Rest I don't understand.
Okay, okay, okay. And what else?
What else
So of
on
course, what about the pulmonary vascular markings? Don't you think they are more prominent? The patient is going to need some diuresis as well. So good thing is cardiomegaly, definitely the RA is definitely enlarged and the RV is also enlarged and there is prominent pulmonary vascular markings. So now coming towards the management. So the patient has come to you. How will you manage? So what are the drugs? As I already gave you a hint. So those patients may need is a digoxin, diuretics, nutrition you have to take care. You also have to give them high calorie formula, even the breast milk. And if you can supplement the tube feedings as well. And yes, those patients may need sometimes prophylactic antibiotics to prevent bacterial endocarditis as well. And sometimes, as I said it, once they start to grow up as well, and still the problem persists, then for such patients, yeah, we may have to consider for the surgical repair using those stitches or the patch, which I said it. And nowadays, we also tend to use septal occluders as well with the surgery. Although yes, there's a very good success rate, in fact, and the growth also catches up very well. In fact, although even if you have done the surgery up to 2 to 3 months post-operative as well, still you may be able to hear the murmur. You may be, as I said it. So post-operative within 2 to 3 months, it's not much of importance, I would say. Okay, so that is one of the really important things. As I said it, CHD, I will try to go through, make you go through all those pictures only. Picture comes and everything else should come into your memory. Like, what is happening, what do you see? So what do you see in the PDA? How I used to remember was the connection is between the P and D, pulmonary artery
aorta,
and hmm. So what happens
aorta
is
arch of
exactly. So what is happening is over here, uh, there's failure of closure of the ductus arteriosus. So the ductus arteriosus doesn't close. Okay. So a lot of times what happens is when there is a premature infant or the infant is born to a mother who has had history of rubella during the first trimester of pregnancy, these defects can happen. And due to this, what will happen is the oxygenated blood will pass from the aorta to the pulmonary artery. Yeah, from the aorta to the pulmonary artery and mixes with the deoxygenated blood, which of course finally goes to the lungs. And then what is going to happen is the blood volume to the lungs will increase, due to which there will be congestion, isn't it? So the name itself is like clear, patent ductus arteriosus. So the ductus arteriosus didn't close, and the combination is happening between the aorta and the pulmonary artery. And what is happening is, because the blood is getting pumped at high pressure through the PDA, in fact, the lining of the pulmonary artery will be irritated and inflamed. And bacteria in the bloodstream can easily infect this injured area. That's why such patients will be predisposed for bacterial endocarditis. About the clinical manifestations, as I already said it to you, uh, they are pretty similar: shortness of breath, congested breathing, disinterest in feeding or tiring will be there. There will be poor weight gain, sweating will be there quite a lot, and tachypnea can happen. In fact, those patients will be having, and as you may also notice it over here, the weight gain will not be proper, the sweating will be happening, tachypnea or bounding pulse will be noticed for such kind of patients. So now, being clinicians, patient comes to you, they gave all that history. Now you have to auscultate using your favorite stats, right? Most of our healthcare professionals, including the doctors especially, they're proud of distinguishing themselves from the other healthcare professionals by carrying the stat. The stat is not for show. It is to help you in making your clinical diagnosis clear. So where do you auscultate the murmur? There's already a star, blue star for you. No one wants to take this blue star. So there will be what is called as continuous machinery murmur in the left intraclavicular region. So for the VSD, what was it? VSD was pansystolic murmur. ASD was wide and fixed split, right? And for the PDA is continuous machinery murmur, like this. And then for the management, how do you manage these kind of patients? What is a special drug which you have to give it for such patients? What is a prostaglandin inhibitor? That is endomethacin. Endomethacin can be given. It tends to work by stimulating the muscles inside the PDA to constrict. And that's why you may be able to close the connection. And of course, with that, you have to give digoxin, diuretics, nutrition, breast milk, a high calorie formula, sometimes nutritional supplements. And for the surgical management, as I said, it is, yeah, if what is happening is that if the infant is younger than 6 months of age or who has large defects, that is causing symptoms like poor weight gain or even rapid breathing as well, that should be considered. And in fact, nowadays, we also have transcatheter coil closure of the PDA, or even the PDA ligation as well, which involves closing the open PDA with stitches, or the vessel connecting the aorta and the pulmonary artery may be cut and cauterized. So now we are, I think, master of the acyanotic heart disease. So what about the cyanotic heart disease? Give me some examples. I already said it to you a few minutes back. TTT. Quick, quick, quick. So what are those TTT?
Tetralogy of Fallot.
Wonderful. Tricuspid atresia, TGV. Okay. So what happens is these are those defects which tend to increase or decrease the pulmonary blood flow. And the primary pathology arises either due to an obstructive lesion or due to abnormal anatomy, or even sometimes both. And the shunt is present is predominantly from right to left, due to which there's shunting of venous blood without passing through the lungs to be oxygenated. And that's why the unoxygenated blood will be circulating in the arteries, and due to which people may notice the patient is cyanosed, right? So a lot of people even say it like this: Lord Krishna had been having what kind of problem? He was a cyanotic kid. Hmm? So, anyways, I'll try to show you a beautiful animation. So, what do you notice in this beautiful animation? What is happening? As I said, CHD is all about imagining. You need not remember things. If you can see, you know it. So, what happens is, as I was telling you, is this is normally the normal blood flow, okay? Superior vena cava, inferior vena cava, coming to the RA, going to the RV, then going to the pulmonary circulation, then finally coming through the pulmonary veins to the L8, then LV and systemic circulation. However, what will happen is those, due to the abnormal development of the fetal heart, especially during the first 8 weeks of pregnancy, a patient can sometimes develop four defects. Four defects will be VSD, PV stenosis, overriding of the aorta, and of course, right ventricular hypertrophy. So what was that? Those four anomalies, as I said it, VSD will be there, overriding of the aorta, pulmonary valve stenosis, and of course the RVH. So that is why it is called as the tetralogy of Fallot. So now you can notice the difference between the TOF and the normal circulation. So what is happening over here? As I already said, it's all about the imagination. If you are able to imagine well, you will not have any problems at all. So the typical presentations are pretty much similar like the other congenital heart diseases, but the babies, of course, will be blue. Yeah, and they become more prominent whenever the baby is crying or the feeding, in fact, and they will be again irritable. They can even faint. You can also notice clubbing of the nails, and the baby will have breathing difficulty as well. So what are the other differential diagnoses of clubbing? I hope you all were taught well, like CLUBBING. They all refer for something else. Okay, I would really like you all to read about it and keep it in mind because that's really important, as I said it. But anyways, for this patient, for the TOF, what happens is due to pulmonary artery stenosis, the RV has to work harder to push blood into the lungs, thereby increasing the RV pressure and size. Due to the presence of the VSD, it tends to facilitate the blood to pass from the RV into the left ventricle, and mixing of blood takes place. And due to the overriding of aorta, what happens is the aorta tends to sit above both the left and the right ventricle over the VSD rather than just over the left ventricle. So as a result, the oxygen uh, poor blood from the RV can flow directly into the aorta rather than going into the pulmonary artery to the lungs. Okay, due to which there will be decreased pulmonary blood flow and poorly oxygenated blood, which tends to cause cyanosis. So how do you diagnose? So the patient comes to you. So as I had said in the ASD, so in the ASD, what was happening? Wide and fixed split. In the VSD was pansystolic murmur. Then in PDA, continuous machinery murmur at the infraclavicular region. Now in the TOF, so the main concept in this is because of the pulmonary stenosis, you hear a murmur, which is present in this area. What is? Left parasternal region. So what type of murmur do you hear? So it is a ejection systolic murmur. Okay. And as I said it, the reason is due to pulmonary stenosis. So regarding the management, what can be done? So it's always advisable to wait at least till 6 to 18 months till when surgical repair can be done. And as I had said it, so it involves closure of VSD with a tangential patch to correct the overriding, and also the pulmonary stenosis is relieved with a patch. So, so then comes TGV, transposition of great vessels. As you may already see it over here, the aorta is connected to the RV and the PA is connected to the LV. So TGA, switch. Huh? So that's why the corrective surgery, which is done for it, is called as the switch procedure. You just take the left to the right and right to the left. And if you change the valves, what type of surgery it is called as? So for example, there was a great surgeon. Okay, now I'll try to give you all a hint as well. Under whom Dr. Devi Shetty was trained in Guy's Hospital, London. So that guy was a great pioneer. So he noticed like what was happening is the aortic valve, because it tends to bear so much of pressure changes, the systemic circulation to the aortic ones, so it tends to get damaged. But what was happening is the one on the pulmonary valve area, it never gets damaged. So what he thought, rather than, what if I just switch? So for example, I put the aortic valve into the pulmonary position and pulmonary into the aortic. What will be the benefit? So the patient doesn't need any anticoagulation and all, and still just with you need not manufacture another valve as well. It cuts down the price, and it's great, isn't it? So who was the pioneer for that? He was also given the honorary title of Sir Ronald Ross procedure. Anyways, okay, that is different areas and all. Too much of diversion, we already did it for today. So as I said it, even in this, there are two types of transposition effects which we all can see. One is the oxygen uh, poor blood, which will be of course blue. So that is the one which tends to come to the right atrium from the body. It will be passing through the RA, RV, and of course into the disconnected aorta back to the body. On the other side, the oxygen-rich blood, it tends to return to the left atrium from the lungs, which will be passing from the left atrium and ventricle into the pulmonary artery and also back to the lungs. So if we see it over here, what happens is, what about the clinical presentation of the patient? So it's almost pretty much similar like one, but will be there in fact. Okay. So what about the management? What's the procedure specially done for such kind of patients?
Is it pre-intubation of generation?
So what happens is, as I had said, if patients are symptomatic, we will have admit to NICU. We need ventilatory support, even cardiac catheterization service as well. We may also do plan nutrition, and by the second week of is done, it's called switch off. Now, what is happening is there a big role is of gene therapy as well, especially for congenital heart disease. So what happens is nowadays in the human genome has already been mapped, and it has been studied very much deep, trying to see for what are those possible genes which can be causing the heart diseases. Okay, so it can. Hello.
Hello,
Hello.
sir.
Your net
Okay.
is being little bit
Yeah, the connection had
poor.
got disconnected.
Yeah,
Okay. Are you all able to see my
I
screen?
cannot see.
Yes, sir.
Others?
Your screen
Wonderful.
has started sharing, sir.
Okay. So wonderful. So as I was already telling,
Fine.
the about the rule of gene therapy, which I was telling. So human gene sequencing has already been done. The human genome has been mapped. Now the scientists are able to pinpoint which gene could be the possible source, or what could be the possible source for the mutation, the gene deletion in the patients with the congenital heart disease, individuals or even in their families, which may be causing all these problems, and which may be causing those protein problems due to which the patient stand for. Okay, and due to which, as I said it, those patients will be having not only problems due to which we can even construct their family gene tree, try to do gene analysis in really in details, and in fact, as I said it, they can even try to alter some of those genes and all as well. I think you would have already heard about uh, those gene cloning, especially the sheep's, otherwise even in different animals as well, like in calves and all. Gene cloning is being tried, gene therapy is being tried, especially in the Western countries and all. Quite a lot of stuff is happening, and that's why a lot of research is also happening in the, not just in the laboratories, for example, trying to see the effects on the mice, or the also on various animals as well, like literally from the fishes, pigs, the rats, and the dogs and all as well, because this becomes really very interesting to see how a single code, the ATGC, their coding, if it changes, it can alter the whole phenotype of someone, of a patient. So isn't it amazing? So if you all will recall, does anyone remember what was the congenital heart disease problem, for example, with with Arnold Schwarzenegger. Does anyone recall Arnold Schwarzenegger? What was the problem?
Dextrocardia. Oh no.
Bad guess. Others, please use the chat box. So there, what I mean is, especially in the West, people tend to admit, okay, what are the problems, what they're having. Even for example, Sylvester Stallone, he had a kid with congenital heart disease who underwent surgery as well, and later on did well. Sylvester Stallone. Then, as I said, Arnold Schwarzenegger. Arnold Schwarzenegger had bicuspid aortic valve. Hannah Montana. Does anyone call Lindsay Lohan? What was the heart problem she had? I had already shown in my presentations. You all should go through my presentations in detail. So, Lindsay Lohan, she had ablation in spite of the lead was atrial fibrillation of young. It is called. Now, as I said, I had this is one of the common things called solitus cytosis. Cytosis is in which everything the normal heart is the left, right, but this means everything gets inverted. So the heart goes to the right side and the left to the left side. And there are a few common associations which can even happen with those problems as well.
What happened?
Anyways, we are almost at the end of our session. So we'll just summarize. I hope are you all able to at least hear me?
Yes, only can hear you, can't see you.
As I said it, we are at the end of the slides, okay? So what happens is, as I had said it is that, where is it? Yes, so this is the last slide, in fact. Now, are you able to see my screen?
Yes.
So today's session, we already learned about the fetal circulation, what are the changes tends to happen in this, and finally also about the congenital heart diseases, the different types, and what about the hemodynamics, and of course, being clinicians, how to assess those patients and also manage those patients as well, isn't it? So are there any questions so far?
Okay.
Let's ask
Yes.
others. Are there any questions so far? So if there are no questions, we'll put an end to today's session. Okay.
Okay.
So,
So can we get
other thing,
the
why we try
presentation
to have
somehow?
these sessions?
Yeah, can we get this
Yeah,
present?
you get the slides.
On WhatsApp or something like that? This all
See,
the PP.
these presentations are supposed, yeah, these presentations are supposed to be for personal usages. What I have seen is like PS slides everywhere and all. Okay, so that should not be happening as well. Okay, and, are there any further questions? because these slides, they take days to prepare. Okay, it takes a lot of effort to prepare them.
Yes, sir.
So it should be done in a. It needs to be respected of the efforts of those people and all, and the faculty members, your program chair, being you now. I'm a program chair for your course since more than 6 years now. 15 was the time when I had started, so now it is 21. But I know some of the students, they took the slides and they were circulating, they were doing their own presentations as well. But of course, just cannot alter their names. I would have given you some extra tasks, but I want